Good morning, everybody. Bore da, and welcome to this webinar looking at nitazenes and the threat that they pose across globally and specifically here in Wales. My name is Caroline Phipps, and I'm the Chief Executive Officer of Barod. So we already know that synthetic opioids, and specifically nitazenes, are present in our drug markets, which poses a significant threat to people who use drugs. Today, we've gathered together experts in the field from across the UK and here in Wales to share their knowledge, inform and help us to be as prepared as we possibly can to minimise and mitigate the threat of nitazenes. So our agenda for the morning is pretty packed, as we wanted to get as much in as possible while we have your attention. We have left a bit of space at the end for some questions, and if you can put the questions in the Q&A part of the platform or in the chat, and my colleagues Sian and Verity are going to be keeping an eye on those so that we can ask them at the end of the speakers' presentations. So enough from me. First up is Martin Powell. Martin Powell is Head of Partnerships for Transform Drugs Policy Foundation, which is an independent charity working towards safer systems of legal regulation for all drugs. And Martin's going to give us a brief overview of the sort of international context in regard to synthetic opioids. And what I would like to say is a big thank you to Martin and Transform, who really helped us in influencing Welsh Government to put on events such as this today. And we did an in-person event in May, and they've supported us and our colleagues in Kaleidoscope to really move this agenda forward. So thanks, Martin, and I can hand over to you.
Thank you, Caroline. Now, I've got 5 minutes, so I'm going to move very fast indeed. And in fact, I'm going to cheat. I'm actually going to read you someone else's speech. So this is from Alexis Goustiel, who is the director of the European Union Drug Agency, which until recently was the EMCDDA. And this is what he said about the situation in Europe in the European Parliament just 8 days ago. I am today launching a call to EU partners on preparedness for and response to new synthetic opioids. Signals are emerging that Europe's heroin supply may be disrupted as a consequence of the Afghan opium ban. We are seeing signs that new synthetic opioids, such as nitazenes, are becoming more available. These conditions create the potential for a perfect storm. We need only to look to North America to see what can happen if we fail to act. I believe we run a very real risk of remaining complacent and assuming that the systems and services we currently provide will protect us. They won't. Now, the context for the head of the European Union Drug Agency saying those things is that the EU had 1,800 heroin-related deaths across the 27 countries in 2022, which they consider far too many. They consider that the many harm reduction measures they've got in place, such as overdose prevention centres, heroin-assisted treatment in many countries and so on, are not adequate and won't protect them. I probably don't need to tell everyone on this call that the UK in 2022 had over 2,200 deaths linked to heroin. That's in just one country. And I think the message there for us is that if the EU is considering its response is inadequate and that it needs to do far more, it really does focus, what we have already on what we have already, what we need to do. And in terms of that Afghan opium ban that he mentions, I was talking to one of the UK's leading experts about this on Friday. There's good news and there's bad news. These things are all relative. So it turns out there are much larger opium stocks in Afghanistan than were previously thought. And his latest stats suggest that we may have something like, it's really hard to tell, but perhaps 3 years worth of stocks that give us a little cushion in terms of we're unlikely to see a sudden sharp drop in the heroin supply, But that's just a window of opportunity for us to act now and get what we need in place. And the other thing with that is we can't be complacent about that either, because the Taliban is starting to move against the opium and the heroin trade, as well as against the opium growing itself, which is still being enforced and extending. So that's really the context I think I'd like to leave you with here is the EU thinks that this is happening. We need to do more. We need to introduce more measures. The experts in Afghanistan say we're lucky in that we have a small breathing space to take that action, that it's not too late to do these things, but really we do have to act. And then the last thing I want to end on is a slight positive note, which is we all know about the situation with fentanyl in North America. Well, we've seen, they've seen now probably a 10% drop in deaths recently, which, you know, is clearly hugely beneficial, is a very good thing, though the levels are, of course, insanely high still. And they think they've delivered that through better access to treatment, through better harm reduction measures, and also some other quite strange things I don't have to talk about here. But where I'm going with that really is I want to leave you with a picture that looks grim, but we can do something about this. There are measures we can implement, and we can actually save people's lives if we act now. Thank you.
Thank you, Martin. Again, you know, it's the urgency. We so need to act, and we cannot get complacent. So thank you for that. A reminder of what we're facing. So next up, I have Dr. Caroline Copeland and Dr. Adam Holland. I'm not going to introduce you to them in terms of where they're from, because I know their slides, they've got that on there, and to save some time. Caroline actually was going to attend the in-person one, but she had a very good excuse. She was giving birth. So it's lovely to see you now today, Caroline.
Thank you, Caroline. I think you're starting us off though, Adam, aren't you?
Yes. Hello, everyone. Sorry, I was struggling to find my unmute button. Can everyone see the slides and hear us okay? Great. Yeah, hello, I'm Adam Holland, and this is Caroline Copeland. And Caroline, do you want to introduce yourself first of all?
Yeah, so as Caroline said, I'm a new mother. My 5-month-old is currently upstairs. But I am also a senior lecturer in pharmacology and toxicology at King's College London. And I also run what is known as the National Programme on Substance Use Mortality, which is a national database on deaths related to drug use that is reported to voluntarily by coroners across England, Wales and Northern Ireland. And we have about 90% of coroners reporting to us at the moment. And so the data that we are presenting today comes from that voluntarily reported deaths from the coroners.
Thanks, Karen. And hello, I'm Adam Holland. I'm a public health consultant. I help Caroline a bit with the National Programme on Substance Use Mortality, and I also chair the Special Interest Group on Drugs in the Faculty of Public Health, which is the professional organisation for public health, the public health workforce in the UK, alongside a couple of other roles. So today we're sort of here to set the scene, really give a bit of context and background on nitazenes, what they are, where they are. Caroline's going to talk about the data from NPSUM pertaining to deaths associated with nitazenes in the UK, and then a little bit about the international context and some questions for the response. So I don't think we need to sort of labour this point, because I think everybody knows this. We have a drug-related death crisis in the UK. Scotland has the highest rate of drug-related deaths in Europe, which did decrease in 2022, but it started to increase again in 2023. And because Scotland's drug-related death rate is so high, it really eclipses the increase in drug-related deaths that the other nations in the UK have seen. So I think over the last decade, Wales had a 40% rise in the drug-related death rate, and England had a 60% rise in the drug-related death rate. This is a little bit out of date now. This is from 2019, but it's quite a shocking figure, which shows that about a third of all of the drug-related deaths in Europe in 2019 were in the UK. And I don't think we have pretty graphs like this anymore after we left the EU, at least from the European Union Drugs Agency. But I would imagine that the situation is quite similar. And yeah, numerous people have said we have a public health crisis related to drug-related deaths, verging on a public health emergency in some areas, particularly Scotland. So there's a bit of background. Sorry if this is a bit basic, if everyone already knows this, but just to so we're all on the same page. So nitazenes or nitazenes, different people say the word in different ways. I'm sticking with nitazenes. I don't know if that is incorrect. I'm sure there are chemistry colleagues here who might have views on it. But they're a class of synthetic opioids. Nitazenes is not one drug, and it's not the same thing as fentanyl. Synthetic means that these drugs are made in laboratories from chemicals. They don't come from plants. Synthetic drugs, that's a broad category. It includes lots of established drugs and medications. So synthetic drugs aren't a new thing that have just appeared. Opioids are drugs that work on the brain's opioid receptors. So that includes things like codeine, methadone, heroin. But opioids are different to opiates. Opiates are derived from the opium poppy. So all opiates work on opioid receptors. So all opiates are opioids, but not all opioids are opiates, because some opioids are synthetic and are not derived from the opium poppy. So nitazenes are not synthetic opiates, which you read in some places. Often nitazenes are being found as adulterants in other substances, so contaminants. But what the concern is, so what happened in the US with fentanyl is originally fentanyl was an adulterant of heroin supplies predominantly. Before in some areas it substituted the market entirely. So now in some areas in the US you expect to get fentanyl rather than heroin. And that's the real concern here, that we might end up in a similar situation with nitazenes. Nitazenes were developed in the 1950s in Switzerland by scientists trying to develop new opioid painkillers, but they were never marketed because of their potency and because of their risk of overdose. Then over the last few decades, there were sporadic reports of nitazenes on the unregulated drug market. So those references there as one incident in the US and one in Russia. But it's only in the last few years we've seen a real increase in the prevalence of nitazenes around the world. And 13 different nitazenes were reported to the United Nations Early Warning System between 2019 and 2023. Because the illegal drug market is illegal, because it's unregulated, we don't know exactly where drugs come from. We don't know exactly how the markets work. But the intelligence that is reported from the European Union Drugs Agency and from the United Nations reports that at least some of these drugs are being reported from China and a few other countries. So a nitazene is due to the shape of the compounds that make something a nitazene. And there are 14 different nitazenes currently controlled under the Misuse of Drugs Act, but there are more nitazenes than that, and more could be created with other modifications to that central nitazene structure. The potency of nitazenes can vary quite a lot. So just for some context, again, fentanyl is not a nitazene, it's another type of synthetic opioid, but fentanyl is 50 times more potent than heroin. Some nitazenes are much stronger than fentanyl. So etonitazene is 10 times stronger than fentanyl, which is 500 times more potent than heroin. So you need very small amounts of these drugs to cause significant side effects and potential overdose. In terms of where nitazenes are, so I'm sure people here working in this field have encountered them. There's various news reports from different areas in the UK highlighting where nitazenes are emerging and causing harms, and internationally as well. So I think they've been reported to the UN from 6 continents off the top of my head. I don't know if you remember that, Caroline, but they're everywhere, essentially, Australia, the US, and they're causing, they're particularly prevalent proportionally in the Baltic states, Estonia, Latvia. The proportion of drug-related deaths in those countries related to nitazenes has increased quite rapidly over the last couple of years. So we've just got a few minutes left, so I'll just quickly whip through a couple of questions for the response and a couple of things to think about. I suppose probably at the forefront of many people's minds, just to mention, this is why we are particularly worried about what's happening. So it's important to emphasize there are lots of differences between the US and the UK in terms of the structure of drug treatment services, of healthcare services, socioeconomic factors, and the specific drugs we're talking about and sort of routes of smuggling. However, in 2012, 2013, in the US, fentanyl emerged as an adulterant of heroin before it substituted many heroin supplies. And then they saw a really precipitous rise in drug-related deaths in the US, with over 100,000 deaths in 2021. So I think this is the worst case scenario for what could happen with nitazenes if we were to see heroin really substituted on a wide scale in the UK. And this is the worst eventuality that I think we do need to prepare for here, but hopefully we won't see the same thing. Also, some other international contexts, as we alluded to earlier on, the Baltic states, Estonia and Latvia have both seen quite big increases in their drug-related deaths, and quite high proportions of those deaths. 48% of drug-related deaths in Estonia in 2023 were related to nitazenes. So that is also obviously very concerning. As Martin mentioned at the beginning, sort of a factor that a lot of people are considering here is whether what's happening in Afghanistan in opium markets is related to the proliferation of nitazenes in Europe. Just to check we're all on the same page here. So I think it was 2021, the Taliban banned the cultivation of opium poppies. Then there was a really big decline. So the pink on this image on the left is poppies, opium poppies. Between 2022 and 2023, they basically disappeared in Afghanistan. As Martin mentioned, there is a lot of opium and a lot of heroin in storage. So this isn't directly leading to an impact on availability yet. However, if you were someone who made a lot of money out of opium, out of heroin, this is a big risk to your future market. And it might make sense that you would begin experimenting with diversifying what your product was, which could be potentially related to the nitazenes that we are beginning to see. But another way of looking at this is how much of this is inevitable. So there are clear benefits to producers, sellers of drugs for using potent synthetic drugs. So to produce nitazenes, it's relatively straightforward, speaking as a non-chemist, as far as I can understand. And you can do it with precursor chemicals that are quite widely available. You don't need acres and acres and acres of poppies, which are susceptible to changes in the weather, which are susceptible to the Taliban coming along and eradicating them. And also they're much more potent, so you need a smaller amount of nitazenes for the same size of market, so it's easier to hide them, it's easier to smuggle them. So whatever happens in Afghanistan, nitazenes probably are here to stay. But this isn't the beginning of the story, this isn't the end of the story. Between 1997 and 2021, nearly 900 psychoactive substances were newly emerging on the European drug market, including fentanyl, xylazine, cathinones, synthetic cannabinoids. So we're particularly worried about nitazenes at the moment, but there's a lot of other adulteration going on, and we have to think about what is going to come next here. I've got quite a few more slides, but I'm conscious we've already been going for half an hour, so I won't. I'll maybe just mention this quickly. I think probably everyone is aware of this, but nitazenes were banned under the Psychoactive Substances Act. So under the Psychoactive Substances Act, the supply and production of the substances controlled or banned under that act is criminalised. This year, 14 nitazenes were then scheduled under the Misuse of Drugs Act. So what that does is it increases the penalties for the producers and suppliers, and it also criminalizes the possession of those drugs. The rationale for criminalizing possession is to act as a deterrent for people possessing those drugs. But most people don't know that they are in possession of nitazenes. They don't actually want nitazenes. So that problematizes that rationale. And it's also, I think, questionable whether increasing the penalties for supply and production is going to help, given the huge profit margins that are available here. And I'm not aware of any evidence that those measures with other drugs have led to long-term changes to drug supplies. So I think it's important to recognise this isn't going to solve the problem. So we need to be thinking about what we do in terms of surveillance. The government surveillance and warning system is still being shaped up. There's, as Caroline has alluded to, there's a lot of limitations in terms of what we're doing in terms of testing and coroner reporting, because of the backlogs, because of the capacity issues. And we're doing barely any public-facing drug checking in the UK, which could be a key source of intelligence that we could be using to get ahead of the market. There's a lot of challenges here for drug services. A lot of money has been injected into drug services, but we haven't seen an increase in the uptake of structured drug treatment, of OST. So we need to ask how we can make those OST and drug services more appealing to people who use drugs. How do we bring other people who use other types of drugs into drug services? So people who use benzodiazepines, people who smoke crack. These slides will probably be sent around. I think so there's a few key studies here that you could have a look at, and you could look at these bullet points without me speaking very quickly over the top of them. But there's also questions about how we can expand harm reduction services to meet the needs of this population. We need more drug checking. We need, like Wedding-Oss do an amazing job based in Wales for the whole of the UK. How do we increase the uptake and provision of postal drug testing services like Wedding-Oss? And a key question for me is how we can take a more pragmatic approach to provide services that supervise or are on hand where we know that people are using drugs. So that's not just in big shiny drug consumption rooms, overdose prevention centres. That's also in hostels, outside health centres. We know people are using drugs there, and we could be doing more under the auspices of existing legislation, but it would be made easier with some legislative amendments, or at least an amendment to the misuse of drugs regulations, to do that more widely. So in summary, I think just some key, points to end on. We need sustained funding. We're waiting to hear what's going to happen to the uptick in drug treatment funding. I think that's being announced later this month, what's going to happen with that funding. We need more research to guide the implementation and changes to services to meet the challenges around nitazenes. A lot of this is happening in the context of broader austerity, where lots of health services and social services that would be protective against drug-related harms, not just nitazene-related harms, a lot of these services really are on their knees. So there's a lot to do to rebuild those services. And we're in a policy environment that makes it difficult to do common sense interventions. And it would be fantastic if the new administration was to make it easier and provide some central impetus for local areas to be providing some more innovative harm reduction responses to nitazenes and other drugs. Those are our emails. There's lots of references there. Sorry, we've overrun a little bit there. I will stop sharing my screen. And also, sorry, I'm dressed like I'm going for a hike. It's very cold in this house.
Thank you. Yeah. Thank you, Adam, and thank you, Caroline. That was so interesting. I could, it's such a fast-moving, dynamic situation that we just need to be, as aware of things that are happening, sort of as much as we can. So that was really fascinating. I'm sure it stimulated people with questions. I know, Adam, that you've got to shoot off, but thank you very much. But hopefully, Caroline will stick around for the questions at the end. I've just been asked by one of my colleagues just around a bit of the tech. If some of you are still struggling to hear the speakers, Verity has pinned guidance to the top of the chat, and you can try and get your sound working. What we think is likely to be your device settings. We are recording this, and we will be sending all the slides around just to reassure you. Okay, without further ado, on to our next speaker from the very brilliant and amazing Wedding-Oss. We have Dean Acreman. So, Dean, can you take us into our next presentation, please?
Yeah, morning, everyone. I'll just leave my camera on a second as I introduce myself, and then switch it off, as I know it does affect the bandwidth, and I've been having a couple of issues this morning. So my name's Dean Acreman. I'm a project team manager for drugs, threats, harms and trends. And I'm also the operational manager of the Wedding-Oss project at Public Health Wales. So Wedding-Oss is a Welsh government funded, Public Health Wales managed collaboration between Cardiff University and Cardiff and the Vale Health Authority to provide a drug testing, drug check-in system It's been running now since 2013. In that time, we've received and analysed in excess of 45,000 samples from a wide variety of different sources. Those samples come from Welsh emergency departments, the Welsh ambulance services, from services within Wales and the wider UK who provide support for people who use drugs. So that could be from problematic OST provisions down to training and employment providers, education providers as well. We get samples that come into us from the police forces of Wales that are non-evidentiary or forensic finds, so it gives us some drug market intelligence and intelligence on drug market trends. We have samples coming from the nighttime economy, primarily through amnesty bins in South East Wales, so across the Gwent and South Wales Police Force areas. We also have samples that come to us from within a custodial setting from HMP Park. We used to receive non-forensic samples from all of the prisons within Wales, but HMPPS have now gone to a central contract for drug testing for the prisons. So the public sector prisons in Wales now submit their samples via that mechanism. But basically what that means is by focusing on consumer level drug markets, Wedinos is a national drug markets trends and threats monitoring system. It's more than just a drug testing system. It's more than just a drug check-in system. We have all these samples coming from a wide variety of sources and feed our information up from local level to regional organised crime units, to Welsh Government, further afield to the UK early warning systems, and wider than that to the Trans-European Drugs Identification Project, the TEDI project, and also to the United Nations Office for Drugs and Crime. So what we're doing here in Wales through our Welsh Government funded project is influencing and informing drug treatment responses and drug policy far wider than just Wales. Now, Wedinos has been seeing nitazenes for a little while. We first had a profiling of nitazenes on the 14th of April 2021 when we received a sample of an unknown white powder from Wakefield. We put that onto our primary analytical tool, which is ultra performance liquid chromatography quadrupole time of flight mass spec, better known as a UPLC QTOF. What this is a rapid testing system. Results can be back within 24 minutes, and it relies on a library of substances. That's a live library that's constantly being updated with new identifications and new alerts. And we were able to profile the nitazene, metanitazene within that sample. Since then, Wedinos has now identified nitazenes in over 250 samples from across the United Kingdom, with the largest proportion of those, as you saw on Caroline's slide, actually coming to us since January of this year. It has changed in the way that we've seen nitazenes submitted to Wedinos. From the first receipt, that first receipt in April 2021 to the end of 2022, we only had 37 samples profiled as containing a nitazene. The majority of those were actually submitted as oxycodone. With oxycodone then remaining the most common purchase intent listed until July of 2023. And at that time, we started to see nitazenes appearing in samples that were submitted in the belief that they were purchased as diazepam. By the November of that year, diazepam was now the most commonly stated purchase intent for samples where we were profiling nitazenes, and that's remained the case since that point. Actually, in our last annual report, which covers the financial year April 23 until the end of March 2024, nitazenes were identified in just under 6% of the samples that were submitted as diazepam. So in just over 1,400 samples, just under 6% of those samples were actually found to contain a nitazene. So we had real concerns around nitazenes being identified, not just in oxycodone, which is another opiate market, but particularly within the illicit diazepam market. Lots of these products that were coming into us were being submitted in pharmaceutical form, as in they were coming in what appeared to be legitimate pharmaceutical packaging in blister packs with patient information sheets in there. And everything about these products was saying to us that they were legitimate substances or legitimate products, apart from when we conducted our analysis and we was identifying nitazenes within them. One of our big concerns was around the fact that many of the individuals who were purchasing benzodiazepines were probably doing so online via online pharmacies, and therefore were unlikely to be engaging with frontline drug services. So they wouldn't be having the same messaging as individuals who were accessing those services, and they may not have been having any information provided to them around naloxone as the opioid antidote, but also wouldn't have an awareness of that antidote either, as they wouldn't see themselves as being opiate users. So we put together an information sheet that was shared with all our stakeholders, including the Royal College of Emergency Medicine within Wales and the emergency department leads there, so that we could raise awareness of individuals who may be coming in the belief that they were having benzodiazepine overdoses, but they may actually be undergoing an opiate overdose. We shared that information with all our stakeholders, everybody that engages with Wedinos, everybody that engages with the substance misuse programme within Public Health Wales, and asked for that information to be cascaded wider. We use the same tagline as Dan 24/7, which is, are you getting what you think you're getting? Around this time, which was November of 2023, Dan 24/7, which is the helpline and directory for drug services in Wales, were doing quite a bit of media, and we thought that by linking in with our tagline, we would increase exposure for both the Wedinos service and the Dan 24/7 helpline. We did a proactive media and comms strategy around that time. My program lead, Rick Lyons, did several pieces to media. We had quite a lot of traction around this within Wales, but unfortunately we didn't get the traction that we were hoping for on a wider UK level, and that was because coincidentally the same day that we did our press release and media release, the NCA released the updated figures for nitazene deaths within England and Wales on the same day, and obviously that picked up more traction in the national news. We provided information and promotion of naloxone amongst non-opiate using groups. Particularly, we had conversations with Welsh Government and drug services around a potential for an uplift in the number of people who were asking for naloxone, but particularly the intranasal spray Nixoid. Again, where we were thinking about stigma, the individuals who were using online pharmacies may not see themselves as drug users, but individuals who are self-medicating, and there was a thought that prenoxide, being a preloaded syringe, may also play into that mindset of stigmatizing as drug users. So providing somebody an opiate within an antidote within a needle may reduce the chances of them taking that substance with them. It did change. Obviously, we were seeing heroin previously through Wedinos, and it is important to say that This does sort of like identify the differences between what WEDINOS sees through our testing as a street level testing service and what crime agencies see, because the National Crime Agency was seeing a lot of nitazenes in powders, whereas primarily in the beginning WEDINOS was seeing nitazenes within tablet form, as I mentioned, oxycodone and diazepam. But in November 2023, we started to see an increase in the number of samples submitted as heroin. Caroline mentioned in her presentation around maybe some of the bias towards individuals who are submitting samples to WEDINOS, and she's right around that. WEDINOS is a self-selecting, self-reporting system. People have to want to submit samples to us for analysis. And the nature of heroin use doesn't really lend itself to a system whereby you have to be forward planning your drug consumption. So you have to want to submit a sample to WEDINOS. You have to either access WEDINOS via the website or via a drug service. Your sample needs to be conveyed to the lab and received at the lab, processed, analysed, and then published on the website. A lot of individuals who are using opiates will have them in their pocket. They've accessed the needle and syringe program. They may already be in withdrawal at that time and wanting to use the substance that they had. So it's really difficult for them to consider engaging in a drug checking system or a drug testing system that has a delay from the point of submission of the sample to the results. But at this time, we did have an increase, and there was around concern. There was a cluster of fatal and non-fatal drug poisonings in the Adamstown and Roath areas of Cardiff amongst heroin users, where there was a raise of concern. There was an increase in the number of heroin samples that came into WEDINOS. Fortunately for us, within Gwent and South Wales, they have a joint scientific investigation unit, so they have their own forensic laboratory. They tested some of the samples that were found at scene and identified the presence of nitazenes. That was it. That allowed us to target our own analysis, but also allowed the coroner's office to provide targeted toxicology. And we were able to link those overdoses to nitazenes. This was followed by a cluster of non-fatal drug poisonings in the Aneurin Bevan Health Board area, and we could really see the drug supply line move up throughout the Aneurin Bevan area as we started to see more samples come in, you know, so moving up to the Caerphilly County, up to the Blaen y Gwent County, and following the drug supply line up through that area. Local services were actively promoting WEDINOS and obtaining samples of heroin for analysis, and that, as I said, really did increase the number of samples that were coming in to us, but really did also allow us to have some real-time intelligence of where nitazenes were being found, in what form they were being found, and the concerns that individuals were having. As with diazepam, we released an information sheet that was again provided to all stakeholders. We had a media day on the 8th of February, where all media outlets that the Public Health Wales comms team liaise with and work with routinely were invited to the laboratory for filming and interviews, again with Rick. We provided support to services around information for nitazenes, but also reassurance around naloxone and its efficacy in an overdose involving nitazenes. We provided priority accessibility to testing for all samples that were submitted via services that were linked to an overdose. Oh, sorry, let's go back one. And that allowed us to really accurately monitor nitazenes within the market. The number of heroin samples since those overdoses has reduced, although we are having samples of heroin from other areas, and I'll bring you more up to date with what we're currently seeing within the drug markets relating to nitazenes in a couple of slides. But first of all, just a rhetorical question. For those of you who are linked with or working in prisons, what do you imagine the substance on that piece of paper to be? Okay, so moving on. So nitazenes in a prison setting. There's been lots of media around HMP Park. 6 inmates die within 3 weeks. Park prison inmates told to throw away the drugs after jail deaths. The media was picking this up as spice because the substance involved within these overdoses and fatalities, individuals had smoked paper. And the most recent article in relation to them from the 27th of August was about 2 more inmates overdosing on super strength synthetic opiates at the prison. That article talked about fentanyl. When we went into the prison following a cluster of fatal and non-overdoses, we provided rapid access for testing for non-evidentiary finds. We provided a nitazene information sheet for the staff, but we also provided, importantly, an easy read document for people who in the prison relating to nitazenes in the drug supply. And that was in conjunction with vulnerable individuals at the Huggard Centre in Cardiff. So we had some peer feedback around the information that we were providing into the prison. In conjunction with the prison, we also did a piece relating to nitazenes and nitazenes within the drug supply that was recorded and played through prison radio, as well as attending the prisons and providing drug market trend workshops to staff and the prisoners themselves on each wing of the prison. So open access drop-in workshops on all of the wings where people could come in and ask questions around drug market trends, drug supply, the effects of specific substances, and we was talking around all the different markets that Wedinos is identifying nitazenes within. Within the prison, the main issue was that the drugs were sold on paper that was laced with a substance. In this form, the prisoners primarily were believing that they were spice, the common term for synthetic cannabinoid receptor agonists, or SCRAs. In discussions with the men, several aired an opinion that the drug was actually fentanyl. So at each stage of the conversations, we're talking about an increase in potency, an increase in risk for adverse effects, because the nitazenes are obviously more potent than fentanyl. Fentanyl is a completely different substance to synthetic cannabinoid receptor agonists. It's more chance of adverse effects as a result of taking fentanyl, more chance of overdose. So every level of information, we was having to constantly take people through the differences between one substance and another substance, the different risks, the different times of onset, the different symptoms, the different effects through those conversations. Through police and Wedinos analysis of the paper from within the prison, we were then able to profile nitazenes on those papers, usually alongside an SCRA, but sometimes within isolation. The paper was being burned on e-cigarette coils or was actually being set alight and the fumes inhaled. One of the big concerns around that was the fact that substances is the most efficient way of increasing your blood plasma levels of those substances. So individuals were having the biggest hit of those substances that they could experience. So from that, what we did within the prisons was really reiterate this message of, in prisons, spice is a term for drugs on paper. You just don't know what that drug is. And then having conversations with people around the raised risks of taking unknown substances. So just to bring you up to date with what Wedinos is currently seeing, from January of this year to August the 31st, we've identified nitazenes now in 130 samples. That is still a small percentage of the number of samples that we're seeing, 2.5% of the just under 5,200 samples that we've analysed. Within that, we've had 8 different purchase intents, but importantly, none purchased as a nitazene. Although in 2023, we did have 5 samples that were purchased as a nitazene. This year, we haven't seen individuals purchasing as a nitazene. So all of these individuals who'd consumed a nitazene did so unknowingly. The vast majority, again, as Caroline mentioned in her slides, were submitted as diazepam, followed by heroin. But as I mentioned earlier, there is some situational bias in that when we was having the cluster of overdoses in South Wales Police Force area and the Gwent Police Force area, we did have an increase in the number of samples that came in, particularly at the start of the year, January, February time, and 17 submitted as oxycodone. In August, oxycodone was the #1 purchase intent for samples identified as containing nitazenes. And then we do get lots of different outliers as well, where it's crossing over drug markets. The one of concern, I suppose, currently at the moment is this one that was submitted as 2CB. So 2CB is a psychedelic hallucinogenic that's often linked to the nighttime economy. And why, even as one sample, we have concern around that is that the Mandrake project in Manchester recently identified 2 samples that were found to contain nitazene that were purchased as ketamine. And we are seeing an increase in ketamine within the nighttime economy. So the concern is that these potent synthetic opioids may now be crossing over into the nighttime economy. And again, as with the diazepam issue, how do we get that message out to individuals who are using the nighttime economy of the potential risk of nitazenes within the market? How do we raise awareness of naloxone? How do we increase the provision of naloxone within nighttime economy settings to ensure that individuals who are using substances within those settings who are potentially at risk of consuming a nitazene are kept safe. And just finally then, to finish off, showing you some of the samples where Wedinos has identified nitazenes. I still think that the tablets at the top portray a sense of safety for an individual who buys those, a sense of validity in the way that they're packaged, and a belief that they are going to contain diazepam. Accord is a legitimate pharmaceutical company. That packaging is exactly as you would expect it. The typeface on it for the serial number and the date are different to all the other typefaces, which is exactly as you would expect. The tablets are contained within blister packets, and the patient information sheets within there are, again, as you would expect. So everything about that would provide an individual purchasing them through online pharmacies, having them delivered to their door with a sense of safety that what they're going to be consuming is diazepam. But as I've said, just under 6% of samples submitted to us as diazepam found to contain a nitazene. And with the heroin market as well, the middle line there, we've got 3 samples. And the reason that I've put up the 3 different samples is to show that it's within different heroin markets, within different types of heroin. So you've got your gravy granule heroin on the left, more towards your light brown heroin in the middle, and towards what is normally seen as your poorer quality black tar sticky heroin, or as the third example there. So yeah, even when you're buying from the same supplier and using those visual inspections that many people often do, same supplier, it looks the same, it cooks up the same, there's a potential for nitazenes to be in the mix for those. That's it for me, Caroline. Thank you.
Thank you, Dean. Again, so fascinating and again, fast moving. I know that you and I discussed in our Nighttime Economy event just very recently around that crossover and how do we get those messages into what can be quite a different way, an area, different messaging, and different partners. Yeah, something that we need to get our heads around. So we have now coming up Gavin. Gavin is our service manager for Gwent Drug and Alcohol Service, and he's going to talk to us about how they have responded to the threat of nitazenes. So Gavin?
Right, 2 seconds. Can you see the slides?
Yeah.
Okay. Hello, so my name is Gavin Jones. I'm the service manager for Gwent Drug and Alcohol Service. I've got some slides to talk through. I'm going to talk to you a bit about our synthetic opiate response within GDAS. So we tried to launch a 10-point plan that includes testing as number one. So as Dean said, we were after the cluster of fatal and non-fatals in South Wales, we really started to push the wedding loss testing amongst our service users, making sure we could get as accurate information as possible from the testing. We then moved on to staff and stakeholder training. So we spent a lot of time designing training packages for staff. We started a new role within GDAS, our harm reduction specialist, which is Gareth Leonard. He's on the call, I think. And he delivered some training for staff and stakeholders throughout Gwent. So he's been and trained an Ivan Bevan Health Board, staff within GDAS, peers within GDAS, so that everybody is aware of the nitazene threat. Naloxone training and supply is next on our list, and it's taken a little turn with the research. You might have seen I copied into the chat. Some people were talking about naloxone and the effect with nitazenes. There's some evidence at the moment that naloxone, when it's given intramuscular, will act quicker with nitazenes, although obviously we're early days with our research. So we made sure we supply as many people as possible. We have a peer-to-peer naloxone group within GDAS, and they go out onto the streets and deliver naloxone to people, whoever asks them, whether it's a member of the public, somebody that uses opiates, a concerned other, and they will train them and supply them with naloxone there and then. So next for us then, and this is probably my favorite bit because I'm a bit of a geek, is monitoring and data collection. So it's about looking for patterns and seeing what patterns might be available, where we might go next, what could be the next option for harm reduction. Number 5 is our peer-to-peer harm reduction. So I talked about them giving out naloxone kits. We, in February, were approached by Welsh Government around nitazene testing strips and whether we could facilitate the training and rollout of them across Wales. So that's something we accepted, but I'll come on to that a little bit later. Information sharing. So for us, this is important. It adds to the monitoring and data collection. So we are fortunate in Gwent that we have a heroin and crack area coordinator role. So Carly's going to speak next after me. So it's about the information going both ways. So we will share the information that we get from our peers or from the nitazene test strips. And then Carl shares information from drug seizures, from fatal overdoses, if there's been any commodity testing, and then our commissioners to round off the whole package. Number 7, we thought it was important to try and engage people that were not in treatment. So we've heard a lot from Dean and Adam about the change in the nitazene market and the fact that it may be now in drug markets where people wouldn't normally access a drug service. So it's important for us to engage those people. We've done that through a variety of public-facing events. We've also designed a booklet that we're going to put in GP surgeries just to tell people about what could be in the substance they're using. Our harm reduction messaging then is next. So we are very proud in GDAS to have a lot of harm reduction messaging. We make sure it's all in the same format. It's easy to understand, so you don't have to have a degree to understand that what you may be taking may not be what you think it is. So number 9, and I should say these are in no particular order, is about staff and users' welfare. So if the worst was to happen and we saw a big spike in nitazene deaths, how are we then going to look after the staff, service users, peers and family that are left behind? So it's about making sure that everybody is in a good place, making sure they got mental health support, because obviously that would be devastating for all of us. And then number 10 is horizon scanning and monitoring again. So it's about looking at what's next. So if we think about 2-3 years ago, we weren't thinking about nitazene in the normal drug supply. So we want to make sure that we're ahead of the curve. So we've got a little bit of intelligence about what might happen next and what we could do better. Next then is to talk a bit more about the nitazene testing strips that I mentioned previously. So we were given the task by Welsh Government, could we find an effective way of using nitazene testing strips for our end users in a way that they could use the tests and that we think that we would get credible information from. So Gareth went away and spent the evening, I think, trying to work out all the maths. And we worked out that if you crushed a substance, so you can use it for tablets as well as your heroin. So if you're a benzo user, you can still test using this method, and filled the little red circle on that business card with enough powder so you couldn't see any red. And then put the powder into a cooker or a spoon and added 1 ml of water. You could then stir the substance into the liquid, dip the test strip, and within 20 to 30 seconds, it would give you a result. So we are cautious that the tests we're using at BTNX, they are first-gen tests. We know that BTNX were about the first to have the fentanyl tests in America, and on the first gen, they did experience some difficulties. So we are accepting that there may be some false positives. For example, in Gwent, so far we've given out 80 of these testing strips, and we've only had 1 test positive that then when we've sent it to Wedinoss is tested negative. So I think that they're fairly good odds on the reliability. I think that if we try to put it in parallel to our urine screening, which we heavily rely on in a drug service, we are on a higher % with these testing strips than we are with the urine testing. So we then had an event in Newport where I invited people from every area planning board in Wales, and myself and Gareth run through the training around nitazene testing strips, how they would be, how we had developed how to use them, and the messaging that would go alongside that. So for us, it's important that even if we have some false positives, we are still having that harm reduction conversation with somebody, so that it may be that a peer on the street is talking to somebody that uses benzos on a Friday night, or they may be a gym user that's using benzos to get a good REM sleep after training so that they could produce more muscle. So it's important that our conversation is there, that we know nitazenes are in the market, and we know that if we are going to use something that could contain a nitazene, we should use with somebody else. We should make sure we have an naloxone supply, and we should be cautious so that we know that if the worst did happen and we had a non-fatal, then there would be somebody to administer naloxone and call the ambulance. So about 3 weeks, I think, after we launched the nitazene testing strips in Gwent, we decided that we wanted to ask some current drug users some questions around nitazene supply, the testing strips, and what people would do if they thought there was nitazenes in the area. So fortunately for us, 100% of the people that we asked had heard about nitazenes. And then we went on to ask them, what did they know about nitazenes? So you can see that we had quite a varied response. We had some saying they were stronger than heroin, some saying it was an anesthetic. 11% of people said it was very dangerous. And only 44% said they weren't sure really what a nitazene was. So then we went on to ask them about what drugs they had heard nitazenes could be in the supply of. Some people said none, which is not brilliant for us, but you can see we've got quite a varied response then, from heroin to crack to spice into what the nitazene could be cut into. So then we asked an important question that we've heard from some other areas especially, is around, have you heard of anybody actively seeking out nitazenes? So 10 out of the 11 said no, and 1 person said that people think it's like strong heroin. So I think that it's important for us that we try to target that percentage of people that could seek it out, so that they're aware of the dangers and we can provide harm reduction advice around that. So we then asked if people were worried about using nitazenes, and the majority said yes. The one that said no said that they weren't worried about using nitazenes because they had saw somebody that they believed was using nitazenes overdose, and they were brought back with an naloxone kit. So then we asked if people know what to do if somebody overdoses from nitazenes, and everybody said that they would use an naloxone kit and that they were all currently carrying a kit. So the next important thing for us was we wanted to know if people used a testing strip and it showed positive, would they still use that substance? So I think that for us, the people we asked were heroin users. So when they were talking about it depends on the withdrawal, I think they were presuming that they had just spent their last £10 on some heroin, it tested positive for nitazenes, and they were already in withdrawal. And I think that we have to be realistic, and if somebody is at that stage of withdrawal, the chances are that they will use the heroin even if there are nitazenes in there. So again, it's just about that harm reduction messaging that runs alongside it. Then we asked if they would use the testing strips and what they would do if it was positive. So they all said that they would use the testing strips. They thought it was easy enough to use. They understood the mechanism of using it and the amount of substance needed. I think that I missed it on the nitazene cards, but it's important that we decided for 1 ml of water and for that amount of substance, so that if somebody wanted to, they could then put Vitsy in and use heroin in their normal way, and they wouldn't waste any of the drug, because some of the research at the beginning from BTNX was to use 5 ml of water and a lot of the substance, and then once you've put it in 5 ml of water, it's very difficult to get it back into a usable state. And I don't think that I know many active heroin users that would be willing to give up that much of their heroin that they've just managed to secure. So then we asked them what they would do if it was positive on the test, and 4 of them said that they would not use the drug and would bring it in for Wedinos testing. One person said they would still use it, and the rest said that they would use but be cautious and follow the harm reduction advice. Gone much quicker than the other speakers by looking at it. So the last slide for us then is about what we might be able to do next. So in GDAS, we've secured an FTIR testing machine. We're currently waiting for Home Office license to come through so that we can offer drug checking in our service in Newport. So the plan would be that if you're a substance user in our service and you've got a substance that you're worried about, or you've used some and it's had a bad effect, they would then come into GDAS, surrender that sample to us. We would be able to test with the FTIR machine and give them some indication as to what is in that substance on the day, but then that substance would then be sent off to Wedinos for testing with the gas spectrometer that Dean spoke about, and give us a much better understanding about what was actually in that substance. I think that's it. I've gone much quicker, Caroline, sorry.
Not a problem, Gavin. You covered all the stuff, and you know, it's just interesting as well to look at, you know, how we deal with issues from a service point of view. From practically, how do we respond as services, and that, I think that'll be really helpful, and I think people will get a real benefit out of what you're doing in GDAS. So our final speaker is Carl. He's going to give us a perspective from police. So can I welcome Detective Inspector Carl Evans to do the next presentation. Brilliant. Thanks, Carl.
Thanks very much. Morning, everyone. Bear with me whilst I share my screen. Just let me know when the PowerPoint comes up. That would be fab.
Yeah.
Excellent
yeah,
stuff.
I can see it.
Okay.
Brilliant.
Okay, let me just rearrange the screen. Right, morning everyone. So yeah, as Caroline said, I'm Carl Evans, Detective Inspector with Gwent Police. I suppose the little caveat initially is some of the stuff that I'm going to go through is obviously being covered by some of the other speakers around the stats and stuff, so I may skip over bits of the presentation, not to bore you with the same information. Just to give you a little bit of background about myself then first. So I've got almost 20 years with Gwent Police, 10 to go. And as it says, not that I'm counting, of course. My first 3 years was in uniform as a response officer in sort of frontline policing. And fundamentally, my 17 years since then has been as a detective, as a constable, as a DS, and as a detective inspector for the last 5 years. In a number of CID departments, so quite a varied background. I've covered sort of intelligence, serious organised crime. Let me get rid of that there. There we go, it's better. Serious organised crime, proactive CID, so your burglaries, robberies, acquisitive crime, reactive CID, which covers your serious assaults, domestic violence, sexual offences, attempt murders, stuff like that. And more recently, strategic roles around domestic abuse project and currently the Hacker DI. So what is the hacker role? So it's heroin and crack cocaine action area coordinator. It's a bit of a mouthful. It probably took me my first 2 weeks to work out what it was and what I was supposed to be doing. But fortunately, I've got a bit of a grip on that now, I think. The role started back in 2020, where there was an application to the Home Office who approved the funding. Primarily, obviously, the title of the role, it was brought in to look at issues surrounding heroin, crack cocaine throughout Gwent. And to work with partners and stakeholders around expanding drug testing on arrest throughout Gwent custody suites. It was extended for 2 years following that initial period, and then subsequently direct funding from Police and Crime Commissioner and Gwent Police has kept the role going from 2023. Currently is funded until April next year, so I'm hoping that the funding gets renewed. I think it's quite a valuable area of business. But we shall find out over the next few months. And I've been in post since November 2023. And as it stands, I think we're the only force in the UK to have a dedicated position to sort of look at the main pillars, which are quite overlapping. So what are the responsibilities of the role? So it's to provide a strategic and operational guidance ultimately to chiefs officers and staff throughout Gwent, as well as working with the partners and stakeholders in quite a few key pillars. Obviously, I've highlighted the main ones of importance we're going to discuss really today. So we've got drug testing on arrest, drug-related deaths and investigations, which obviously ties in exactly with what we're discussing on the forum today. I sort of collate regional, local and intelligence from the prisons as well to make sure that gets disseminated across Gwent Police. And again, I'm a link in between our own intelligence services, organised crime and serious organised crime disruption teams, which are our guys and girls that do the proactive work then to sort of break down the links around organised crime. One of the pillars is around naloxone training to staff and roll out across Gwent. So again, that's quite key to what we're talking about. And I also look at and lead on spike-ins and suicides as well across Gwent. So you can see there's quite an overlap between a lot of those areas. So governance and reporting structure, I'm not going to bore you too much with this. I suppose more importantly around the drug-related deaths, which is the link for today. So we've got a local and a regional drug threat group, which is chaired by Gwent, that has all significant sort of partners and stakeholders bi-monthly and quarterly. I link in directly to the Gwent Substance Abuse Area Planning Board, the APB, which is a massive bit of the work and really important. And I'll discuss that a little bit more detail later on. Project House Builder, again, which I'll go into more detail, is the national response to the synthetic opioid threat. And we've also got now a real-time reporting pathway, which again, I'll go into a bit more detail. Okay, so I know some of this has been covered, so apologies, but what are nitazenes and xylozenes? Well, we know nitazenes are synthetic opioids. It's a man-made substance, and we know it was developed back in the 50s for pharmaceutical research. It was never approved for medical use because of the strength, ultimately, and the dangers that were identified very early. Generally, they're manufactured in China, which we've already said, and they're imported then to bulk out and adulterate, really, with heroin and also cocaine. Because of the issues that we've already discussed in Afghanistan and the supply of heroin, etc., which is why ultimately these synthetic opioids have come to our attention. So more recently, I suppose in the last 6 months, and certainly up in Scotland, which we know has got sort of one of the most significant death rates from drug-related deaths. We see in pills as well, sort of pure nitazene pills that are coming in from Poland, we're aware of, also Baltic states as already discussed, and they're being sold or purported to be sort of street benzos and Valiums. So there's a real danger obviously with service users taking those thinking they're something else. As we've said, from March 2024, 15 synthetic opioids, 14 being nitazenes, are now controlled under Class A, 1971 Misuse of Drugs Act. However, xylazine is slightly different, so this is still not illegal. I know there's talk through Parliament, obviously, to try and get the statute in place and the legislation to do the same as xylazine, but at the moment it's not illegal to possess it, etc. And ultimately, it's something that's been approved for veterinary medicine as a tranquilizer, so it's used with other controlled substances to prolong the high ultimately when used with the opioid. So what's the current picture? There's a national threat, as we know, linked to nitazenes and xylazenes and the synthetic opioids, and this is why we're all coming together to have days like this and share the knowledge. As it stands, and this is sort of up to the last week, there's over 330 synthetic opioid-related deaths across the country since the reporting began in June 2023. From a bit more of a local perspective, for Gwent, we've had 18 drug-related deaths or suspected drug-related deaths since the 1st of January this year. Fortunately for us, it's been quite low in regards to synthetic opioids. So only 2 have been linked to those through commodity that's been found at the scene and tested, and then subsequently the coronal toxicology results to show what's actually in the deceased person's system. I know, obviously, Wales were quite small. South Wales have had quite a significant hit, unfortunately, with synthetic opioids and nitazene deaths, and the majority of sort of deaths in Wales, which are up to 34 as it stands, linked to synthetic opioids, I think, are in the South Wales area, and some of those in Park have already been discussed by Dean earlier on. So, as we said, significant threat because of the strength, and these substances have been adulterated to heroin, but also coming in pure pill form, and significantly stronger than the primary drug. And I think these stats came up earlier, so between 50 and 500 times stronger than heroin. But what we do know through the intelligence as well is this stuff is being added or adulterated at sort of distribution level, so probably top end of the organised crime group within the UK, so London and West Midlands. Obviously, the stuff itself, synthetic opioids, the nitazenes are coming from China, so it's getting mixed at those levels then, as opposed to real local levels. So for us, you know, which would be sort of Newport or in the valleys, so it's happening before that, we tend to think, with the intelligence as it stands. So what's our response from Gwent Police then? Well, one of the biggest things is we link into Project House Builder. So this is the national response to the synthetic opioid threat. So there's fortnightly meetings which contain force drug leads from almost every force within the UK. I think there may be a small handful that aren't signed up to it, but the majority are. This obviously allows us to report any nitazene deaths, xylazine deaths in. We can share intelligence. There's peer support then from senior investigating officers within the NCA and the NPCC to provide guidance to sort of myself as a force lead, and then obviously to any investigations that are ongoing around synthetic opioids. So we've got intelligence sharing and best practice. So again, that's my role, linking between the regional intelligence to our own FIB, the Force Intelligence Bureau, and our proactive serious organised crime teams. I can get the message out directly around officer safety and on any protocols that are coming in as best practice, obviously from House Builder and nationally, and to make sure that we get all that out to our operational staff as well, to make sure that we are doing everything to protect our staff and the public in the best possible way. So we've also got a drug-related death awareness flagging system in place now. So this is through our control room. So when an incident gets reported that could be a potential drugs death, it's flagged up within our force control room, and we've got a drugs death protocol that gets invoked. So that provides lifetime guidance to attending officers and standard operating practices around scene preservation, evidence preservation, and the sort of risk assessments that I've already mentioned for officers at the scene. So that gets initiated. A detective is now allocated to investigate the suspected drug-related death. Previous to this, it would be a uniform response officer, but that now sits with a specialist detective from serious organised crime or one of the proactive CID teams to take ownership at the earliest opportunity. I'm notified as the hacker DI. The duty detective inspector also is notified to oversee, and importantly, Operation Adder is initiated. So what is Operation Adder? This is a massive tool for us. Ultimately, it's the fast track commodity testing of anything that we find at a suspected scene of a drug-related death. So we're really fortunate in Gwent that we've got joint forensics shared with South Wales Police, so they've got the same capability and capacity in this area. And ultimately what it means is any commodity that we find at a drug-related death, we can get a forensic report back within 2 to 5 days. And this is something that previously would have taken 6 to 8 weeks. So you can see the benefits around that early identification of substances that may have caused the death. And it'll link in then with some of the other work that I'm doing as hacker and Gwent Police have got in place. So just to touch on the naloxone rollout. So again, that's part of my responsibility. We've currently got 324 operational frontline officers and custody staff that are trained and issued with naloxone. And I've now embedded the training in our sort of learning and development yearly first aid training. So what that means is every officer goes through that every year, as it says. So ultimately, we should have over 500 officers now trained within the next 12 months. And I get a monthly report back on that. So just to give you an indication, it's not on here, but we've had 18 uses of naloxone in an operational capacity. So that's outside of our custody environment since the 1st of January this year. And all 18 of those have had a positive response and positive reaction from the service users, the individuals that we've had to use it on. So I saw some of the questions in the tab earlier around, how many uses, etc. And I've sort of reviewed all these, and it's really hit and miss. So on occasions, one use of the nasal naloxone, which is what we issue in Gwent, has had the positive reaction and brought people back. But on other occasions, we've had to use 3, 4, 5 kits. And I know in custody, whilst I haven't got the stats, there's been occasions where they've used up to 12 or 15 kits because somebody just hasn't come round. But ultimately, the science tells us that there's no harm, and the protocol is to keep using those kits every couple of minutes if there's no response. So that's obviously what we do. But ultimately, 18 out of 18 positive hits. So that's massive from my perspective. So this is probably the biggest bit of work that I've done since I've been in this role. And it's having a real-time reporting pathway. So it's me linking in directly with key stakeholders and partners. So the area planning board representatives, obviously Maria Evans, Leanne Dalton and Dr. Julia Lewis, the coroner's office, GDAS, obviously Gav has just done his presentation, Project House Builder, which I spoke about, obviously Wedenos, Dean has been on today, and everything else I've spoken around the regional local intelligence. It's having that immediate reporting facility. So if a drug death comes in today, we've got the standard operating practice in place. I get notified, as does the duty DI, and everybody knows that we link in straight away with these key partners in the APB to give the initial circumstances of the the suspected drug-related death. And key then is getting those commodity tests done within 2 to 5 days, sharing those results with the partners, and then moving on from that, the coronal toxicology, which can take up to 2 months to come back. That isn't sort of a fast track, unfortunately, for that at the moment. But sharing those results as soon as they're back as well to, confirm ultimately what is in the system of that deceased person. Because as we've said, sometimes there can be anomalies with commodity or product that's found at the scene that may not ultimately show in the bloods of the deceased person, especially if we're dealing with, as we have on occasions, deaths in sort of multi-occupancy flats where you can't really guarantee the commodity that we found at the scene was used by that individual that sadly died. And ultimately, it's about having those continued open lines of communication, sharing that information to assess the threat, assess the risk, and the harm that are linked to not only the person that's died, but obviously those individuals around them, which obviously Gav touched upon, and the wider public as well. So I suppose we look at what are the benefits of this response. For me, it's that accurate risk assessment and threat identification. Like I said, it's timely information. It's on the day of a suspected drug-related death, getting that information, getting that intelligence out to all the partners. And ultimately, it's a two-way process, like Gav mentioned, is having that any relevant information back as early as possible from GDAS, from health, and from anyone else in the APB, so that we can just really understand what our risk is and what we need to do about it. It's a joined up approach then to those local and wider threats that we've identified. That allows us to give a targeted response. And as Gav has mentioned, it's that safeguarding advice and provisions then that can be put in place to, you know, family and friends or other service users around the individual that's deceased, but that wider stuff as well, through health, through the APB, getting the message out, you know, to health, to education, to anyone else that needs to know, and really informing everyone in a timely fashion, just getting that information out there and acting on it. For the coroner's office as well, again, they've got up-to-date information of what is found a commodity at the scene. And because we're talking here about unexplained, non-suspicious drugs deaths, so we, you know, this isn't where we think someone has had an influence or an impact or has forced somebody to take drugs where it becomes suspicious. So this is 99% of the drugs deaths that we will deal with in the police. So again, that could inform the coroner and give them a bit more information really early doors as to what they may be needing to look for around synthetic opioids in their coronal toxicology, which takes a few weeks, obviously, to go through. Our local picture can be fed back to that national process, then to House Builder, which again, the more information intelligence that we've all got as agencies, you know, the better prepared we are to deal with this ongoing threat. You know, it links in directly with our main policing priorities, preventing and detecting crime. Obviously, it's organised crime groups ultimately that are, you know, getting these drugs in the system through county lines and other methods. So that's what we're here for, is to sort as the police, but ultimately saving life and limb. That comes, you know, before everything else. And the big thing, I suppose, for me is the big takeaway is synthetic opioids are not going away anytime soon. That's pretty obvious. You know, the political picture and everything else going on in the world now is going to have an impact, no doubt, but ultimately it isn't going to disappear off our radar as professionals. So for me, it is literally all about that timely, accurate, collaborative working practices, getting them in place with your respective partners, stakeholders, your APBs, because you can then manage that risk. You can understand it, you can manage it, and ultimately, hopefully, save some lives, which is, you know, what we're all here for. Yeah, so that's it pretty much from me. I will leave my details up here if anyone wants to get in touch for anything, then you can do so. Like I said, this role is going until certainly next April. Hopefully it'll go on from there, but we shall see. If it doesn't, this work won't disappear. They will just be potentially split between some individuals in other departments within Gwent Police. So this isn't going to stop the work. So we'll have to see how that plays out. But yeah, that's it for me. Thanks very much. Hopefully it was informative for you.
Thank you very much, Carl. That was very informative. And long may your role last, really, and it would be great to have that replicated in other police forces. You can see just by your presentation today how it links in with all the partners, which you rightly said is the only way that we can work to mitigate this threat. So thank you very much indeed. So we're ahead of schedule, guys. So we've got time for some questions. I'm going to ask my colleague Sian, would you be able to ask the questions where they are? And I know we've had a few, I've been looking at the chat a little bit, and there's been quite a discussion around naloxone. I think Carl sort of explained the approach to that, but there may be still some questions there. So over to you, Sian.
Okay, great. Thanks, Caroline, and thanks to all the speakers for some great presentations today. We've had some of the questions that were asked in the chat and in the Q&A answered in the chat. I'm going to try and lift out and prioritise the ones that haven't been answered yet. So Joanne Clark asked a question for Caroline. Is Caroline back on the line? Because I know she had to pop off for her baby.
Yeah, I don't know whether she is back on the line. Ask it anyway and see if you know, any of the other speakers can answer it. Or I could get Caroline to, you know, at later date.
So one of them was specifically around where were the 2 deaths in Wales that Caroline had mentioned that included nitazenes.
Maybe.
Yeah, sorry, do you want me to come in there?
Yeah, brilliant, thanks, Carl.
Yeah, so in we've had 2 in Gwent, and if you bear with me 2 seconds, I'll get me spreadsheet out and I'll tell you what areas they were in now. So I don't want to take another question quickly, and I'll get those details up.
Yeah, good idea.
We'll come back to that then. There was also I'll ask the questions that have come in from Dean. So have companies like Accord, whose packaging has been counterfeited, commented on this phenomenon, and are they going to do any counterfeit protection on their packaging?
We have previously in the past been contacted by some of the pharmaceutical companies as a result of us putting this information out. And we're currently working with the MHRA and providing them with images of all the packaging, the serial numbers, the batch numbers, sorry, of the samples that are coming in to us. So I would say at the moment we'll to address that.
And there was another
Thank you.
question for you, Dean, around the patient-friendly leaflet that you mentioned in your presentation. And there was a harm reduction nurse on the line from Newport, Helen Williams, who's wondering whether she and other people can have access to that patient-friendly leaflet.
Yeah, I can put all the leaflets that were put into the presentation into an email to be shared out. I'm happy to do that.
Great, thank you, Dean.
Thanks,
Do you
Dean.
want me to just jump back in on the Gwent there?
Yes, please, Carl. Yeah.
So obviously
thank
bear
you.
in mind this is just Gwent, so I haven't got the details of South Wales, Dyfed or North Wales. But the two that we've had, we've in fact had three since reports started, but I went for the 1st of January. We did have one in December, which was in Newport. And then we had January in Caerphilly and February in Newport. And we haven't had one linked to nitazenes or xylazines or any synthetic opioids since then, unfortunately.
Okay. Thank you very much.
Thanks, Carl. I know that Martin Powell has put a response to Matt Jones's question, but it came up during Dean's presentation, so I was wondering whether Dean also had a view on this. Said, we heard that they have underestimated the heroin stocks in the supply chain. New estimate that there's 3 years stock of heroin in the supply chain. Is that from today or from the year 2023 when the poppy field's reduced by 95%?
I wouldn't be able to answer to that one at the moment, but one of the other interesting things in relation to the opium supply is the uplift in opium production in Myanmar, formerly known as Burma.
Oh, yeah.
And how much they're now producing there as well. Martin's just come on the screen, so
Yeah.
I'm assuming that he's got some input around that as well. So yeah, thanks.
Yeah, I mean, there is some increase going on in Pakistan and in Myanmar, but it's nothing like enough to counterbalance the drop in Afghanistan as of current times anyway. And actually the ban has further increased in Afghanistan. They've actually further reduced the area under poppy growing at the moment. And yeah, with the 3-year figure, that I put a bit more detail in the chat about that. It's also lick your finger and hold it in the air, really, around these things. There are so many variables involved. But the core thing here is, even if there are 2 to 3 years in the supply chains, all that's going to do is tell suppliers that's, to start moving now and organising alternatives and exploring alternatives, which is what we think is happening. And given that no one knows what the Taliban will do, I think, as Adam said, any supplier who wants certainty is going to be looking at these synthetic opioids. So we can't count that as anything other than the smallest of breathing spaces to get our act together a bit more too.
Yeah, thanks, Martin. Your phrase, the window of opportunity, but that is a short one and we need to act. Any other questions, Sian?
Yes, there was quite a big discussion in the chat around naloxone, where it says it's positive to see most forces are carrying a life-saving product. However, I'd be interested to know how far it reverses overdoses of the more potent synthetic opioids. For example, does there need to be stronger versions of naloxone to counter the more potent drugs? And we had a few questions of similar nature in the chat.
Any of our speakers like to respond to that? I mean, my understanding of it, or Gavin, I thought you'd come in, but my understanding of it, we're just watching and learning as we go through, aren't we?
Yeah, Gavin did respond in the chat, just giving the standard advice that more than 2 kits should be given out to to at least 2 kits, but more if we know that they're using nitazenes or they've been at high risk of overdose before. And it also seems to be that the intramuscular injection is more effective than the Nixoid due to the bioavailability at the time in the body. So it's just about making sure that we give out the intramuscular kits and we're not just giving out the Nixoid, but multiple kits is definitely the way to go.
Gav, did you want to say anything else?
I think Sean covered it all. I mean, obviously the only issue for us is the research that was published is in line with intramuscular and then Nixoid. And the same week the research came out, we had an email from Welsh Government saying the Nixoid stocks are really low. So advising people to use the Pebbles, which is a lower dose again. So I think it's just a watching brief, and we'll keep an eye on the research.
Thank you. Thank you. Any more, Sean?
Yeah, Gavin, while we've got you, there was a question that Richard Jones asked around how much do you actually need to cover the red circle in the nitazene tests? He was asking, is it about a quarter of a £10 bag? If you could give some guidance on that, please.
I think it's about 1/8 of a £10 bag. So it's even less than than a quarter. So it's a very small amount. And obviously if you've got a pill, so if you're a benzo user, you can crumble a bit off the side and crush it up and fill the circle pretty quickly with a small amount of the tablet.
Great, thanks.
We also had a question from Mark Gilman. This was during Caroline's talk again, but I'll open it out to all speakers. Do we know if methadone or diamorphine or buprenorphine based OST provide differential protection against overdose?
Any of our speakers respond to that?
I think they're all, they're all added into the mix, don't they? It's, you know,
I think
the preventative side is getting somebody on a script, and then the work that goes alongside that. The risk that you have is the same as if somebody was on methadone or a opiate substitute, and they're using other opiates on top.
That's right. Yeah, we had that question, didn't we, Dean? Yeah, we had that question in British and Irish Council event. I mean, the fact is that you know, we know the evidence that if people are in treatment, they're less at risk from drug-related harm and death. How they interact in terms of those medications, I can't answer that, but we can certainly ask Caroline and Adam if they've got any comments on that and share that when we share some of the slides.
We have a question here for Carl. Some service users have reported administering naloxone to friends who've gone over, but not calling emergency services for fear of legal repercussions from the police. What is the police's approach to this?
I think, to be honest, I think Gav has sort of answered this. Underneath is that ultimately the message is just call 999, because we wouldn't necessarily have a call then from health. You know, it's going to go get the paramedics, get the ambulance out, but ultimately that may not even filter through to us. And if it does, the reality is saving life and limb. You know, somebody coming round is ultimately what we're there for first and foremost. And practically speaking and operationally, unless somebody's there then waving drugs around and we've got commodity and we need to take some proactive stance on that, as long as the individual has come round, and you know that's what our goal is.
I'll just chip in
Carl
there.
Martin. Yeah.
I'll just chip in there as well. This is more broadly about the relationship between and trust between people who use drugs and the police, and it's about how we go about improving those sorts of relationships so that you can reduce that fear and the trust, and actually carrying police being very public about the fact that they carry naloxone, that they care whether people who use drugs live or die, and that their first priority is going to be saving someone's life, is a crucial starting point for that conversation and building that relationship and trust. And it's why I'm delighted to hear Carl talking about this. I had a conversation with the Metropolitan Police, MOPAC, the equivalent to the PCCs in London. The Met is refusing to carry naloxone, and they're obviously by far the biggest police force. You know, my starting point for that is, if you want to build better relationships as a police force with your marginalised communities, this is the way to go, not saying this is someone else's job. So yeah, bravo to police here for that, but it's only a starting point. It's then where you go with that in terms of the conversations you have.
Yeah, thanks, Martin. I was going to say, just to add to that as well, what's I think been massively impactful is that relationship that I've got now and we've got as the police with GDAS, with Gav and Gareth here, because obviously it's the service users they are directly in contact with. So I know that the guys over there speak really highly of the police, you know, and this working relationship that we've got. So that, I suppose, is exactly what Martin's talking about. It's just building that trust, you know, because if the GDAS managers can be seen working with us, you know, and I'll regularly go over for a cuppa with them over there as well, so I'm seen and about. It's definitely building that trust, building that relationship, and ultimately getting the message out that yes, we are the police, you know, and we are there to arrest bad people at times, but ultimately the service users are not the people we ultimately want to target in this. It's the organised crime group, it's the dealers. That's our priority, not, you know, the people at the end of it who are the ones suffering.
Absolutely. Thank you, Carl.
We have
Sean?
2 questions. Carl, while you're on, one is directed towards you. So does Carl have access to police seizure purity levels? Does it look like purity of wholesale quantities is falling yet or becoming more expensive? I was told still around 20,000 per kilogram of heroin. Sorry. Sometimes up to 26,000 per kilogram last autumn. Clearly, we're all worried about what the opium and heroin coming out from Afghanistan might and will run out.
Yeah, no problems. Quite a few questions in that. So in regards to the purity, the majority of the time, there's a slight issue with the forensic provider around getting the purity, and a lot of the seizures, if it's on a local level with the neighbourhood policing teams, wouldn't routinely be done. Yes, seizures through our organised crime teams and our organised crime unit, obviously, who are the ones targeting the upper echelons, if you like, you know, the OCGs, they would go through some of that testing depending on what's found. But ultimately, yeah, the price has doubled in the last year of heroin, you know, which is a knock-on effect from the issues in Afghanistan. But I think the intel that we're getting as well is that whilst there are, I think we had sort of 3 to 5 years potentially of stock left, like any other business, as soon as you start withholding a bit of that, the price rockets. So that's what the farmers are doing their end. So they could even drag those amounts out by drip feeding it through, which is what we're sort of starting to see, which then has the impact on the pricing doubling in the last 12 months. And that, as we know, has that knock-on effect with the synthetic opioids then, because the high-end dealers our side still want to make their margins, but they're paying more for it in the first place. So like any other business, and there's supply and demand, literally. So everything seems to be working against us in those terms at the moment. But yeah, it's a difficult position.
Thanks, Carl. Any other questions? Another question?
Yeah, we actually just had another one pop in, and there was one before, and these are largely for Wadino. So Dean, there's a person here who thinks that they saw that cannabis was one of the drugs tested positive for nitazenes at Wadino. Given how widely available it is cannabis often a drug seen adulterated by other substances, for example, nitazenes and spice, and is it easily identifiable?
For us in Wadino, we've had one. It's the same with THC vapes. They are at the moment outliers, I suppose. We have in the past seen them adulterated with synthetic cannabinoids, but not very often more recently. The sample that was identified with cannabis, I think, goes back to 2022. You know, so it's part of the presentation because it informs all the markets that we've seen it in. But it does appear just to be that outlier. In terms of identification, sometimes, you know, depending on the size of the crystals that you may see for the synthetic cannabinoids, you might identify that there's something a little bit different about it. But they can be really difficult to visually see any difference, especially if it's ground up as well. You know, I know some of the bags of cannabis is sold as ground bags already, so you know it is difficult to to identify anything really without an analytical tool.
Great. And another question for you, and other people might want to contribute to this as well. But it says, what sort of alert systems do we have in place to communicate the fact that a new detection of nitazenes have been found in the drug supply in a local area? And can we do better to get the message out to potential users when new detections are found?
So I'll leave that probably to Gav to describe the great system that GDAS has, and maybe even Carl for when lines are found and information sent out that way. But for us, ours is via the harm reduction lead system, and our stakeholders, and sending things out. It's very rare that we put out a national alert. For us, national alerts would be tied to overdose and analytical findings of the substance toxicology reports. So we'd be looking for a number of different triggers for that, where we do put out information sheets. They're shared via the harm reduction leads, and hopefully then cascaded via those to local drug services and local drug services further afield. We also use the needle and syringe program. So the NEO system that has an news alert ticker tape system across it. Anybody who's used that may have recently seen the one about the identification of nitazenes in Cardiff and the Vale, that was running through September through September, as that was identified at scene of an overdose in that area. So we've got a multitude of different systems for getting that information out. But I think it's really important to remember that Wedinos as an analytical service is myself informing the information out and the analyst. So there's two of us. So we really are a hub and spoke system, and the services that provide into that hub are as equally important for cascading our information out.
Thank you, Dean.
Steve.
Gav, do you want me to jump in now for the chronology? It works well.
Yeah, go on.
Brill, okay, yeah, so I did put it in the chat. I think it's probably answered this question, but so my role, I'll when there is a suspected drug-related death, I'll link in on that day with the APB, obviously, that includes Gav and GDAS, to get the initial circumstances of the incident, obviously, you know, who's unfortunately deceased, but anyone that's linked to them at the scene as well, any family, friends, get that information out so that those initial sort of measures can be put in place, which obviously Gav will speak about in a minute. Slightly wider than that, then those commodity test results, which come back within 2 to 5 days, as soon as day of receipt of those. Again, I get those details out to all of the partners, all of the stakeholders, and ultimately we can have a meeting then, and anything that needs to go wider in regards to health, education, that's obviously managed through the APB, and if anything needs to go alert-wise nationally, whether that's Wales or wider, touch wood, fortunately we haven't been in that position yet, but again that would just be managed through the APB with all the protocols in place there. But ultimately, from a police perspective, as soon as the information comes in on that incident or the commodity or the coronal blood tests on the day, they get sent over and discussed between us all as partners. Gav?
Yeah, good, Carl. Yeah, I think I touched on it a little bit in the presentation. So we've got a text system that we brought into in GDAS. I know that Barod more widely are looking at expanding that across the whole of Wales. I think that the only thing that we do internally is we are cautious about what alerts we send out. So we don't send out an alert unless it's been confirmed through either Wedinos or via Carl through JSIU when it's been tested down at Bridgend, just to make sure the information we're giving is accurate. And in terms of like what Dean was talking about in the background, so in the background we have Gareth's post, who goes through the Wedinos results, looking to see what's in Cardiff, looking to see what might be in Swansea, what might come into the area next, just to try and analyse those results a little bit.
Thanks, Gav. Thank you. And yes, we are looking at the messaging across Barod.
I think we've just got time for one more question, Caroline. There was
Okay.
also in the chat geared towards
Okay.
Dean. So does Wadinos have any information or idea about the dosing of pills or powders? For example, a pill with 60 milligrams of metanitazene is more dangerous than one with 10 milligrams, or is the data merely qualitative?
Wedinos is primarily a qualitative system rather than a quantitative system. We have done some time-specific things in the past where we've looked at the doses of diazepam in samples that were submitted as diazepam that were small round blue tablets and blue all the way through when you snap them. So there's some consistency in what we was looking for there. Those samples are in milligram doses. What we can say for that is, for what we tested, it was between 7.1 and 11.7 milligrams. So if individuals who are making these tablets in clandestine laboratories are struggling to accurately dose a 10 milligrams tablet, how can they accurately dose some things that are in micrograms? So the equivalence is unlikely. And we have done some, again, time-specific projects where we've looked at flualprazolam, flubromazolam, and nitizenes. And the doses vary within those. In terms of nitazenes, it's not something that we've undertaken to this point, but looking, like I said, at doses of other illicit tablets and other substitutions, there's been no consistency or dose equivalence in what we found.
Thank you.
Thanks. That's all the questions, Caroline.
Okay, so we've come to the end of our webinar. I'd like to thank all our speakers for sharing their time and their knowledge with us today. I hope that that's been useful for you who are attending. We will get all the slides, and we've recorded this then, so any colleagues that you think they may be interested and couldn't make it, please share as wide as you can. And thank you for attending today. So yeah, that's it from us. Thank you very much.